joining us in the conceptual basis of urology course, which we run on every first and third Saturday of the month. And we try to cover basic topics in urology and trying to get some of the best speakers from around the world to speak to our trainees and our junior consultants and other urologists in Pakistan and elsewhere. Tonight, we are very fortunate to have Dr. Tariq Al-Shaiji, who is a consultant urologist in Kuwait. He works at the Miri Hospital. He has a special interest in andrology, female urology, and neurourology. And he's going to talk about sacral neuromodulation, something that is not very frequently done in Pakistan. And I think from our trainees' perspective, this will be a wonderful talk to get a basic understanding of sacral neuromodulation and its role in voiding dysfunctions. We also have Dr. Mavish Nadeem. All of you know Mavish very well, graduate of Khan Urology Residency Program with and she then moved to UK. She worked and did fellowship in female urology and reconstruction. She's currently a consultant urologist in Southeast in Leeds. So it's wonderful to have you back again, Mavish. And I would like now request Dr. Tariq Al-Shaiji to please make his presentation. So thank you very much for being here. Floor is yours, Dr. Shaiji.
Yes, Assalamu alaikum to everyone. I would like first to thank the organizers of the Conceptual Basis course webinar series for this invitation. And I hope this to be fruitful for everyone. So today we're going to talk about the application of sacral neuromodulation in the management of voiding dysfunction. And as mentioned earlier, this has become an important area in the management of refractory voiding dysfunction. So these are my disclosures. So I would like to kick off the talk by just giving you a couple of examples of how this treatment is being applied and used. For example, in case one, we have a 30-year-old female. She has a history of chronic idiopathic urinary retention with some overflow incontinence, but no urgency to void for 2 years. We did ultrasound, which showed decreased sensation, and I would say complete absence of detrusal pressure for voiding, so no contractility, with a voiding diary reaching up to half liter. The patient used to do clean intermittent catheterization about 4 to 6 times per day. We performed the percutaneous nerve evaluation in 2003. At that time, she didn't like it. Then we removed it. We repeated it. And then we got 60% improvement. She underwent sacral neuromodulation using the InterStim device, and she was able to void without a significant PVR. Case 2, 48-year-old female with idiopathic overactive bladder, severe frequency and urgency. She did have urgent continence using pads. Urodynamics did show sensory urgency. She was feeling miserable, and she's been refractory to many medications. And then she underwent staged InterStim with more than 80% improvement. So what is pelvic neuromodulation as a definition? This is a therapeutic alteration of the activity in the either central, peripheral, or autonomic nervous system. This can be done electrically in our case, or pharmacologically if you are injecting botulinum toxin, but in our case by means of implanted devices. Now, the idea is that you would have an implantable system that stimulates the sacral nerves, which eventually modulate the neural reflexes that influence the bladder, the sphincter, and the pelvic floor. And by doing so, we're getting the therapeutic effects. When we talk about the potential application, we do know that it is FDA approved for urinary urge incontinence, clinically known as wet overactive bladder, also dry overactive bladder in the presence of urgency and frequency syndrome, and also for non-obstructive voiding difficulty or retention. Now, when I say voiding difficulty, it doesn't have to be a full complete retention. It can be incomplete voiding or a complete retention, or even inability to initiate normal nutrition. There are some other non-FDA approved off-label or what we call emerging applications, including bladder pelvic pain syndrome as a syndrome or full-blown interstitial cystitis. It's been used for sexual dysfunction, neurogenic bladder dysfunction, pediatric voiding dysfunction, and some other non-urological indications, for example, angina, chronic migraine, Parkinson's disease. But when it comes to pelvic area, it is FDA approved for fecal incontinence and also constipation. When you talk about the history of sacral neuromodulation, it started in 1997 when it received its first FDA approval for urge incontinence. 2 years later, approved for urgency, frequency, and non-obstructive retention. And then in 2002, it received the full FDA approval for overactive bladder in general, either neurogenic or non-neurogenic. But with neurogenic, it's for non-neurogenic. For neurogenic, we'll come to talk about this later. Then in 2002 was also an important year because this year was the year where the fluoroscopy and tined lead were introduced, which caused a paradigm shift in the application. 2006, the small stimulator introduced. 2011, it received the approval for bowel indication. And then 2015, they approved the Verify evaluation system and also more indications to follow. Now, as I told you, in 2002, there was an exponential increase in the application of the treatment because of the introduction of this, what we call it, percutaneous tined lead placement, which basically moved from being an invasive procedure to a minimally invasive procedure using fluoroscopy. And in terms of guidelines, almost all the guidelines now having sacral neuromodulation or pelvic neuromodulation as an integral part for voiding dysfunction, which are refractory to conservative and first-line treatment lines. Now, the question is, do we know the definitive mechanism of action? No one actually knows. However, there are some proposed mechanism of actions because it's still not well understood, and there are quite a few possible mechanisms when it comes to how it works. However, if we want to make it simple, it's assumed that neuromodulation affects the neuroaxis at various levels, and by doing so, it restores the balance between the excitatory and the inhibitory regulation at various locations within either the peripheral or central nervous system. So it's not really a bladder-specific therapy. It's central efferent modulation. It does target reflexes centers and the cordon pons. That's why it treats both overactive and retention by blocking ascending sensory pathway inputs. And by doing so, it turns on voiding reflexes by suppressing the guarding reflex pathways. So if you look at it, it's like a human software analogy. Now, when I teach the resident and the trainers, I always tell them, imagine that you have your personal computer or laptop, which is jammed or hasn't been working well. What do? You try to reboot and to restore it to default. And this is, in simple term, how it works. So when we talk about the potential mechanism of action, look, if we have a patient who has urinary retention because of abnormal storage reflexes, you apply sacral neuromodulation, and this tends to normalize it and end up with a normalization of the retention. Same thing for overactive bladder. You have an abnormal micturition reflexes. So you apply sacral neuromodulation, and then you restore the balance between the micturition reflexes and the storage reflexes, and then you end up with normalization of the overactive bladder, either the wet or the dry part. So sacral root stimulation is usually preferably placed as the third sacral nerve root. Sometimes you can get away by placing it in S4. However, what you want to aim is S3, which is then connected to an electrical stimulator, which is eventually, if it's successful, is implanted. And so what you are looking for when you do the stimulation, this is an important slide, is you're trying to cannulate S3 because it does affect the autonomic functions and the striated muscle of the levator and eye. And what you want to look for, if the patient is under GA, then you want to look for response from the muscle. So you should get bellows movement, which is pulling inward or deepening of the intergluteal fold. What you look at is pulling inward of the anus. Also, you may get plantar flexion of the great toe. Sometimes if the nerves are too sensitive, you may get also plantar flexion of the other toes. Now, if the patient is awake, and this is the case if you are doing percutaneous nerve evaluation, then the patient should feel pulling in the rectum, extending forward to the scrotum or labia. So when we talk about patient selection, now you need to rule out neurological lesions, MS, spinal cord injury, Parkinson's, spina bifida, anything that is neurological, which I will talk about in a bit later on. Of course, you need to rule out anatomic abnormalities, because if you're having some abnormalities in the sacrum or area or the sacral nerves, then it's maybe difficult to insert, or if you insert, they won't be any good response. Of course, the patients need to be capable to operate the system, because eventually the patient will be carrying a programmer and controlling himself or herself. The need of MRI used to be an important part, but this is not anymore. I will mention this in a bit. Of course, other contraindication, such as the use of shortwave diathermy or microwave diathermy, because the energy that is transferred may be harmful to the patient. But the most important point is the patient need to pass the screening test. If the patient has 50% either subjective or objective response, 50% or more, then they are a candidate for insertion. Now, as I told you, for neurological lesions, one of the main problems is that many of these patients may need annual MRI or regular MRI. That's why it used to be a contraindication. Now, having said that, you have to be careful with the neurological lesions, because the clinical efficacy that is seen in those patients may be less than those who are idiopathic in nature. And of course, the need of MRI, this is not anymore a problem. Now, in terms of factors affecting patients' decision, we performed a study here in our center in Kuwait, and to see what's the best way to get the patients agreeing to undergo such a treatment. Because when you talk to these patients, you're telling them, listen, I'm having this implant, which is a foreign body that will be implanted and you'll be living with it for many years, then it's not easy. So we found that there is a multi-step ordered approach for counseling these patients. It included meeting with the patient for the first time with a doctor to introduce the therapy. We then give them brochures to read about it. We give them a number of patients who underwent this kind of treatment who are willing to talk, and then they can talk to them. Then they should meet with the programmer who would show them models and will also explain some of the daily issues that may face, and also to explain to them the programmer. And then eventually, the last thing is the second meeting with the doctor. We found that this approach is the best approach to have the patients going for treatment. So pre-procedure, of course, patients counseling is critical because you need to reassure the patient and manage the expectations. And then once it's been decided that this patient is a candidate, then implantation proceeds in 2 steps. A test phase, and then either implantation if it's successful, or lead removal based on the response that is seen at the beginning. Of course, voiding dairy is important before and during. Usually we found that 3 to 5 days each is enough, because the data that we get from the voiding dairy and also the patient's subjective response will act to determine whether the patient is a candidate for treatment or not. And so once we decide, we have 2 ways of doing the evaluation. There is a basic evaluation versus advanced evaluation. Now, the basic evaluation, or the peripheral nerve evaluation, this is a less invasive treatment. It uses a non-anchor test lead, which is connected to an external pulse generator. Temporary lead typically placed in an office procedure using local anesthetics without the need of fluoroscopy. What we usually use is manual or anatomical localization. The test simulation can go only up to 2 weeks because it's non-anchored and it tends to migrate if you leave it further. If you get a result, whether it's positive or negative, then the lead must be removed because it doesn't have tines. Positive result, if you get positive result, then that's really the problem. If you get a positive result, then you have to insert a tined lead again to reproduce the same results in the next phase. So that's why the response is lower with a higher false negative seen, because it is less accurate. But those who go and do this kind of treatment, they do it because it is less invasive and, of course, less expensive. The next is the advanced evaluation. This is more invasive. It used a tined lead, which is connecting to the external pulse generator. This can be done in a hospital setting, usually under general anesthesia. What's good about it is that you can leave it up to 4 weeks, and sometimes you can extend it to 6 weeks if you want, because the tined, the lead does have tine, so it does stay in its position. It shouldn't migrate, and it has 4 electrodes, which means it will allow you to have more programming options for the patient as opposed to only one program of one lead. Because it remains in a place, and thus when you go and implant for second stage, if the patient passes the screening test, then you do not have to remove it. The result should be the same. All what you need to do is to connect it to the battery, which is implanted. So the response rate is higher, up to 90%, because it is more accurate with less false negatives. The problem, as I said, it is considered more invasive, and of course, more expensive. But if you want to do both, here is the flow. Let's say you're doing a basic evaluation using a percutaneous nerve evaluation, which is at the left-hand side. If this is successful, you proceed to the implantation. If it's not successful or inconclusive, you can still go and do an advanced evaluation. And then based on that, you proceed. Whereas in an advanced evaluation, you do it, and then it's either successful and you proceed with implantation, or it's not successful, then you explant the wire or the lead. And so when you look here, you have the old versus the new tined lead. I'm sure you can see in the old system, it's an invasive procedure. You have to have it being an open surgery. Now this is done only through a small, very tiny incision with the lead and using fluoroscopy. And of course, the test stimulator also has undergone changes. It used to be more bulky, bigger. Now we're using the Verify evaluation system. It's much easier, simpler, and even there are more technology transformation, which I will talk about in a bit. So now let's say now the patient passed the screening period and you're going to implant. We implant over the gluteal area as lateral as possible. Usually it's good and advisable to mark the patient prior to implantation because you want to avoid the pressure area where the patient sits. Now, some people like to implant on the dominant hand side of the patient. However, you have to be careful because if you do that, let's say the dominant hand is right, but your stimulation is left, it means you have to cross the midline with the wire, and then the risk of possible migration or breakage is slightly higher. The depth is about 2 to 4 centimeters. Make a pocket almost the size of the IPG, tunnel the electrodes to the pocket, connect it to the IPG, and then insert the IPG in the pocket. We use antibiotic swash throughout stage 2 just to minimize any risk of infection. But in general, the risk of infection is pretty low. And the end result should be looking like this image. Now, the battery itself, or the interstim or the IPG, this is the old interstim 1 as we see. This is non-rechargeable. It is big. It has a power limit of 10.5 volts. It does have an extension lead. Now, this used to be the norm, but this is now obsolete and not being used anymore, completely replaced by IPG interstim 2. Again, it's a non-rechargeable, smaller in size, although the power limit is 8.5 volts only, but it doesn't need extension lead. So there is no extension lead. It's the battery, which is connected directly to the tine lead. Also, more technology emerged for the battery, which I will talk about in a bit. Now, there are also, or there used to be what we call it advanced options, such as the Synergic, or what's called twin system for bilateral stimulation. Very big and bulky. It requires special programming with a special icon programmer. Again, this is now obsolete. If you want to do bilateral stimulation, then you need to insert bilateral neuromodulation. Of course, postoperatively, the IPG is switched on. It's programmed with different electrodes mapping to give the patient a comfortable stimulation. Now, the patient needs to feel the stimulation, but it needs to be comfortable and non-painful. You can give them up to 4 programs to try and switch between them as they wish. Of course, they need the patient's lifelong surveillance to manage any device-related or programming-related issues that may arise. This is just to show you how big and bulky it was and now how it became. which also underwent some changes recently. And this is what I will mention now. The technology has actually transformed and evolved so much recently. Now, when we look here, since 2017, 2013, they introduced the Verify system. 2 years later, received FDA approval. Then we moved to a digital programming using the smart programmer, which is basically a Samsung phone. Then they introduced the antibacterial envelope, which you don't have to use, but this is something they introduced. And recently they introduced the, which is the revolution in this matter, the MRI safe, compatible battery. There are two of them. One of them is chargeable and one of them is non-rechargeable. So they have the MRI safe tined leads, meaning that those who needs MRI can still undergo MRI safely without having to remove it. In the past, anyone who needs MRI and either having an implantable system, then the entire system needed to be explanted, or the patient, even if there is any chance that they may benefit from this treatment, they won't be able to have it because of them having the need to have regular MRI. We have the recharge-free neurostimulator versus the rechargeable neurostimulator, which is of course smaller, but it requires charging at least once to twice per week for a few hours. Of course, we have the enhanced evaluation system using the Verify system. We moved, this is the clinical program line and the patient's program line, how it evolved from being very big and bulky to only using a smart mobile phone. And then it depends whether you are a patient or a clinician. You just need to download a software to control the system. Now, when you talk about complications, the very nature of this mode of therapy, of course, mandate 100% reoperation to replace the IPG at some point. Of course, this is mainly not the case for the recently introduced rechargeable battery, but all the entire old system and also some of the new systems still at some point, if the battery is gone or wearing off, then you need to replace it. Now, adverse events are usually related to the implant procedure, which now, because we're using a minimally invasive technique, then it is not common. The presence of the implant itself, of course, this could be related to the implant itself or to the stimulation. And all of these also are not very common. Now, the most common adverse events include lead migration, implant site pain, and infection. However, the majority of these events do not require surgical intervention. And so a study by Siegel, which is one of the pioneers of this kind of treatment, showed that pain at the neurostimulation site was the most common cause. And pain itself, most common cause of pain is the stimulation itself. And then this is easily treated by reprogramming or changing the parameters of the programs. Now, it's not a surprise that the revision ratio and the events ratio dropped dramatically when the minimal invasive implant was introduced in 2002 by Spinelli. So also other reason why the adverse events and the revision ratio decreased because the learning curve has improved. Of course, introduction of the new IPGs, which are smaller, less bulkier, the placement of the IPG in the buttock instead of being placed in the abdomen during the early days, and of course, introduction of the tined lead. When you talk about the clinical results, data for bladder control is sufficient and solid regarding its clinical efficacy and superiority. There is a success seen at 12 months with a durable effect and sustained efficacy at 5 years. Many studies have confirmed that, in addition to recent studies, including the famous INSIGHT study. So, to conclude, sacral neuromodulation offers hope for refractory voiding dysfunction. It should be considered when other minimally invasive measures failed. The mechanism of action remains to be defined. The procedure is safe, minimally invasive, can be done in an office-based or a same-day procedure as a staged manner. It is an evolving technology, and we are observing and seeing improvement in this technology every day. And the long-term effectiveness and safety are well documented. Thank you so much.
Thank you very much, Dr. Tariq Al-Shahiji. It's a wonderful presentation, and I think for audience who have some experience and audience who have absolutely no experience, this presentation would really add to their knowledge, their understanding of this technique. I will kick off asking Dr. Mahwish Nadeem to have some comments, and if she has any questions. We are also fortunate that we have Dr. Nuzhat Farooqi, who's a consultant urologist at Aga Khan University, and she's also have great interest in female urology and uro and reconstruction. So Mahwish, the floor is yours.
Thank you very much, Dr. Shaji. That was a wonderful and comprehensive talk. You have covered almost everything. And surely there has been a great evolution in how sacral neuromodulation was back in the days, and now it has been. And I think for various reasons and with experience, the new literature suggests that the implant site pain and infection rate has significantly gone down to 3 to 4%, which it used to be around 10% before. So just to get a little bit of your input about your personal preference about BMI in these patients, do you consider sort of a cutoff when choosing your patients for sacral neuromodulation?
That's an excellent question, because to be honest, the problem is not with the BMI. I didn't have problem with implanting morbidly obese patients. The problem is afterwards. And I actually published editorial regarding this, because you have patients, usually this is a problem for them. Once they feel good and happy with the implantation and they are obese, they now think about losing weight. And then when they lose weight, usually if they are morbidly obese, they go for surgical manners such as sleeve gastrectomy or bariatric surgery. And then once they lose weight, the problem here starts being clear, which is either migration or breakage, or most commonly exposure of any part of the system, either the IPG or the battery. The problem, if it's exposed, in theory, it should be colonized and then you have to remove it. Although we have tried not removing it and just covering it, and it worked, but this is, let's say, off-label and it's anecdotal. But to be honest, I usually, if I have an obese patient, I tell them, listen, why don't you proceed with your weight loss program or surgery first, and then once you're ready and happy and you reached your, let's say, desired weight, then we can proceed. But to be honest, I cannot just tell them, I'm not going to implant you, but I usually tell them this is advisable.
Thank you very much. So that's really interesting, because the practice in the UK is usually, I know some people are more comfortable than others regarding BMI, but your point about change in the weight, so either a lot of weight gain or weight loss, whichever way it goes, can really impact how your neurostimulator will work. And just a further addition to it is extreme sports. So if somebody is in weightlifting or horse riding, we have a couple of those who are avid horse riders. So that probably is not my favorite patients to implant.
Yes, absolutely.
The other question was,
absolutely.
yeah.
Yeah.
The other point was about, in terms of your treatment algorithm, where does sacral neuromodulation falls for voiding dysfunction? Where in those algorithm, where would you offer them SNM for voiding dysfunction?
Well, it depends. Are we talking about overactive bladder, either wet or dry, or retention? Now, of course, for overactive bladder, my threshold is not low, because we do have good treatment available with all these pharmacological treatment available, and the recently introduced beta-3 agonist. So, and then also we have the botulinum toxin, which is something you have to offer. So usually, once they become refractory, then I start offering them either botulinum toxin or sacral neuromodulation. But some patients may benefit or may be more suited, best suited for one compared to the other. So it is usually third line, depending on the patient. If you have a very elderly patient, it may not work, or it's hard, or it's kind of hassle for them, then maybe they go with botulinum toxin better. Now, however, when it comes for retention, then the threshold is slightly lower, because you don't have much to offer. You can give off-label alpha blocker, but this may not work. And then you end up with clean intermittent catheterization. Some patients do not like it. Some patients really hate it. But again, you have to tell them, well, if this doesn't work, you may eventually need to go back to CIC. So the threshold for retention is less than, I would say, I would offer it earlier.
Brilliant. Thank you. Just before we go to the MCQs, just one more question regarding your last comment about the urinary retention patients, because we have very less to offer them. So if they fail one test, advanced test, or would you offer another just because they don't have a lot of options?
Well, if you're talking about PNEs, of course, well, I don't do PNEs, to be honest. I used to do them, and I found that doing staged is better and faster and more durable. So if they fail that, if they fail PNE, I would offer them staged. If they fail staged, and I can always do bilateral or check the contralateral side. There is no contraindication, but again, only if they are desperate, because it's unlikely to work really.
Thank you very much. Over to Professor Atta for the MCQ poll.
Thank you very much, Tariq, and thank you very much, Mavish. Ready with the poll. We're going to have 10 questions, and our panelists, including Dr. Tariq Al-Shaiji and Dr. Mavish Nadeem, and we will have input from Dr. Nuzhat Farooqi as well on this. So feel free to, so that's the first question. Kindly go through the questions carefully. You will have enough time. Cast your vote, and then our panel will help you if you have not been able to correctly answer that, what is the correct answer and why. So you can vote now. Don't hesitate. Your identity will not be disclosed. Vote. You can only be wrong. Is everybody comfortable in voting? Do you have problem, technical issue in voting? Please raise your hand and we will explain the process. Yeah, So, Sharif, they can't see the voting screen. People have raised hand. Can you explain the process, Sharif?
Just give me a second.
So I think it is sorted out. People are voting now. Okay, I think we should stop the poll and look at the results. Great. So about 50% have voted for interstitial cystitis, and the rest have voted in various percentages, some of the other answers. Dr. Nuzhat, do you have any comments on this poll?
No, I think it's very obvious and the answer is correct.
So, Dr. El-Shaiji, is there any indication of intractable symptoms in patients who have interstitial cystitis? Is there some modification over the years where this could be an indication?
Yes, we tried to let's say debate this a few years ago, because it depends. When the interstitial cystitis, are you treating the pain component or are you treating the voiding component? Now, usually the voiding component would get better. If the pain gets better, then usually it's short-lived, which means it may get better for 1 year or 1.5 years, but then this improvement in pain tends to disappear. But at some point, many people thought that maybe this should be an indication, but they're still debating it. But it depends. Are you implanting it for pain or for the urgency or frequency part?
Mavish, is the NICE guidelines favoring this as a contraindication to SNM?
So that is very interesting, because if we look at the NICE guidance for indication for sacral neuromodulation, it doesn't indicate interstitial cystitis as an indication. However, if you look at the painful bladder syndrome, or VPS, and in that algorithm, they do mention sacral neuromodulation. However, funding could be an issue in the UK. So often these patients, if they have got an urgency frequency component and we have urodynamics proven reducer overactivity, then we can offer them SNM. However, pain is the issue, as Dr. Sherji has just mentioned, that it's not a very strong indication, and often they took the route of pain team, and they offer SNM. However, the evidence is not very supportive.
Thank you, Mavish. Can we go on to the next question, please? So, which patient is not well suited for current neuromodulation therapies? So there are some case scenarios. We will give you extra time, go through each scenario carefully. And then our panel will help you in understanding the concept of this question and why this is not a good indication. Right. I think we should stop the poll now. And Mavish, again, I think majority have voted correctly. Any comments why insulin diabetic with areflexic bladder and non-obstructive retention is not an indication for SNM?
So yes, this is the correct answer, and there's several factors. So first, if you're talking about just the neuropathic bladder minus the areflexic component, then there is evidence that it might be helpful for storage type lower tract symptoms. But if you're looking at the areflexic bladder, because usually these patients have the underlying neuropathy that affects the bladder, so it is unlikely to respond to sacral neuromodulation. They will have high post-void residual, and this kind of neuropathy usually doesn't respond very well to sacral stimulation. So yes, there is evidence that neurogenic lower urinary tract dysfunction is an indication, especially in the multidisciplinary context, and if you have tried other options. So if you look at the recent literature, the systemic review in 2021 suggests that about 66% improvement in symptoms by sacral neuromodulation in neurogenic patients. However, that population is mainly patients with detrusor overactivity, neurogenic detrusor overactivity. So yes, this is the right answer.
Great. Dr. Shaji, any comments?
Yeah, I totally agree. It is the right answer, but also whoever answered B, this is tricky because again, cerebrovascular accident is considered neurogenic, and it depends. If the patient is having severe detrusor overactivity, then they are unlikely to respond well to neuromodulation, although you can try it. So, but again, you have to take everything in context. Now, the patient needs to be quite independent, sorry, let's say, and able to handle this kind of treatment, able to control their own programmer. So, old age is not by itself contraindication, but it's one of the factors that may predict, let's say, minimal response or suboptimal response.
Right, thank you. Let's move on to the next question. So I think this answer, we expect a good number to answer this question correctly. This has been addressed like the other points as well in the presentation. Okay, it's about 50% have, more than 50% have now answered. Can we end poll? So what I'm seeing, Dr. Shaiji, is that your presentation has really made an impact. Majority have answered the questions correctly. So any comment?
I think it's just a
straightforward question.
Yeah.
So it's just a test of your understanding of the anatomy and where it should really be. Okay, let's move on to the next question, please. Okay, it's a case scenario, so please read it carefully and then answer the questions. Okay, I think about 2/3 have responded. So let's stop here. And Mavish, could I ask you to make a comment? And what is the current practice about having an S&M, and what are the potential complications with an MRI?
So yes, I think this is, as Dr. Shetty mentioned in his presentation, for new devices, this has not been a concern for last 2 years, 3 years or so. We have got all MRI compatible. In the UK practice, we have 2 main companies that offer sacral neuromodulation for urology indications, and both offer MRI compatible device. However, if you are taking over old patients, you should be aware that they might have a device that is not MRI compatible. So in that case, they cannot go ahead with MRI. So you must check. So all these patients are issued with a passport, so device passport. So you must check what is the made, what is the product number, and then you can check with the company if it is MRI compatible or not. So if they have an old device, it means it is not MRI compatible. But for the new devices, they are all compatible. And that is why I think the intake of patients with neurogenic condition has on rise now, because they have limited options. Previously, they were denied this option, but now they're offered because all devices are compatible with MRI.
So what is the main concern, Dr. Shaiji, with MRI and S&M?
Well, it's mainly heating of the leads. It's not the pacemaker itself, because the pacemaker is not the one. It's even if you have an old pacemaker, it's still okay with MRI. It's the lead that may, if it gets heated, then it can injure the underlying nerves. In the old days, if what's really okay is if you want to do MRI, you can still do MRI of the head or brain only, although there are some areas that they managed to do MRI with a special, let's say, setting in the MRI. But again, that was some short series. They're not really something we can rely on. So the main point to take, if it's an old system and it's beyond the head, then you need to take it out.
Okay, let's move to the next question, which is very similar. So no, I think not this one, the next one. So case scenario and patient with multiple sclerosis. You can vote now. Okay, I think we should stop the poll now. Dr. Al-Shaiji, I think it's quite obvious that the confusion with the older literature and the current recommendation, our delegates have not been able to answer this question appropriately. I think we cannot really blame them. Is body coil and endorectal coil similar concerns, or one is preferable over the other? MRI scans?
They are the same. I think they are the same. And also it depends on the MRI radiologist who's gonna do it, because some may accept the risk. If you talk to the patient, they use a special setting.
Mhm.
Now for this question, if we didn't have the MRI compatible introduced, then C should be the right answer. But with the now the new one, then, and I don't think if you are going into an exam, you will be asked about this, because obviously they will, they will apply the new, let's say, guidelines. But whoever answered A, you have to be careful. When you have DSD, then you're talking about obstruction. Okay, it's not mechanical, but it's still obstruction. These patients are not a candidate at all for this kind of treatment.
Right. Let's move on to the next question for the sake of time. So really a C1 MCQ with a lot depend upon your recall and understanding. Great. I think we can stop the poll. Over 2/3 have voted already. Mavish, quite correctly, majority have voted correctly for option E as 9 centimeters from the tip of the coccyx. And both are correct answers. Any comments?
No, I think that's a correct answer. And we obviously use fluoroscopy for this. And I think they have marked it all correct.
Thank you. So let's move on to the next question, please. Okay, I think we can stop the poll. This is interesting, Dr. Al-Shaiji, and I think you have touched upon botulinum toxin and its potential role, which at times is underestimated. So any comments about people answering C and E rather than D?
Yes, well, for E, definitely this is not the answer, because you're talking about a pretty invasive procedure. Okay, it is still there, but you have to make sure that patient is refractory to everything first, because botulinum toxin injection is a straightforward, minimal invasive treatment. Okay, maybe it's not permanent, maybe you need to repeat injections, but you don't want to proceed with augmentation before trying botulinum toxin. Also with bilateral stimulation, as we said and mentioned earlier in the lecture, bilateral stimulation, if the patient fails one side, they are unlikely to go for improvement. And if you do, let's say, bilateral, this is only done as a desperate measure if everything else fails before you proceed with anything invasive. So botulinum toxin would be the treatment, the right answer.
Yeah, thank you. So move on to the next question, please. Next question, please. Okay. Right, thank you. And Paul now. Well, Mevish, it's a general principle in surgery that if you have an implant or a device and it becomes infected, we know that it's very difficult for any orally or intravenously administered antibiotic to have a role. So I think majority are right in saying that one of the safest thing is to remove the device. Is there anything else that you would do before you would make this drastic decision?
So yes, it's a very good question. And I agree with majority that you end up removing the whole device if it's a full-blown infection. Obviously, it states the patient is febrile local site edema. So if we change the scenario a little bit where we say there is a superficial wound site infection, patient is not unwell, then there is a role of trying antibiotics, getting your input from your microbiology colleagues, because in a very small, but there's a small fraction where you can probably salvage the situation and you can treat it. But I agree that in majority of the cases, it's a full-blown infection. There is, if you have a dedicated uroradiologist, you can use ultrasound of the local site to assess if there's a collection before making the decision of removing. But if you are clinically convinced this is an implant site infection, then the right thing for the patient is to remove the entire implant.
Great, thank you. So let's move to the question number 9. Right. So thank you very much. I think Dr. Shaiji, you have talked about this in your presentation, and would you like to elaborate a little further about urodynamics and its role? And some of them have answered that, although majority have correctly answered it.
Yes. Well, we do know that what makes the difference in terms of deciding is passing the trial period. That's what really matters. Now, doing urodynamic is important for me, at least. I do it for every and single patient before I proceed with implantation, because it does help me with the decision, and it does help me with also giving patients maybe some percentages regarding failure of the treatment. But it is not this that will decide. It's the screening phase that is the point that it will help you to decide whether to proceed or not. You have to pass 50% subjective and objective, but once you do that, it doesn't mean you have to implant. This is where you tell the patient you are a candidate. If you get less than 50, then it's not worth it.
Yeah, great. Let's move to the last question of this evening. And then we can have some closing comments from our panelists. It's a bit long question. Remember to scroll down. There is an option E as well when you're answering. Yeah. Great. So I think we can stop here. And I must say that it couldn't be a better end, Dr. El-Shaiji, to this evening's session, as majority have correctly answered question number 10, indicating their understanding of this is something that I must tell you in Pakistan, it's really a rarity if it is being performed anywhere in Pakistan. Nuzhat, correct me if I'm wrong and if somebody is doing SNM. So from that perspective, and as majority of the participants here are from Pakistan, they've really benefit from your presentation and from the discussion of our very elite panel of people who have significant experience in this. So any last comment from you, Mehwish, and then Dr. Shaiji?
Dr. Nadeem?
Yeah, just a little comment. I think there was a question about, because somebody marked it correct, so I just wanted to clarify that concept of a bedridden patient. So any patient who is at risk of pressure sore would not be a candidate, because the last thing you want is the implant to be extruded out of the implant site. So you have to be careful. And I think that is the reason we were talking about BMI earlier. So if somebody is really on the lower side of the BMI, we have to be really careful in selecting those patients as well, because especially if they're going for non-rechargeable device, which is relatively bigger than the rechargeable device, then it could be an issue with the protrusion out of the skin, and pressure sores will only make it worse. So we have to be very selective.
Yes, I totally agree. And there is one thing I think someone, or maybe few of the attendees, I think, asked about PTNS. Now, this is something I will briefly talk about. Now, PTNS, as we know, tibial nerve stimulation, it's also being used. It's mainly used for overactive bladder. It hasn't shown good success for retention. And what you need to know about it is that it's done differently. You're talking about a tibial nerve that you have to stimulate once for 30 minutes over 12 sessions, and then you may get an effect for 3 months, but then it's not durable. You may have to repeat it again and again and again. So that's the main difference. Of course, now there some new leads are coming to the market. You have one that is implanted, and you do not have to have it hooked up to a small stimulator where you can do it wireless. But again, this is still in its infancy. But it's all about durability. That's the main difference between pelvic neuromodulation and percutaneous tibial nerve stimulation.
Thank you very much. First of all, my apologies for exceeding time, but I think it was a very, very fruitful discussion, and we have some really clarifying statements and points coming from two of our panelists. This presentation, once approved by Dr. Shaiji, that it all the other courses are available on PAUS Karachi, which is Pakistan Association of Urological Surgeons website. So we will seek your permission, and if you allow, we will send this whole webinar on our website for anyone to see in any time of their convenience.
Sure, no worries.
Thank you very much. Thank you very much, Dr.
Thank you very
Mavish,
much.
being here today, and Dr. Shaiji, and all the participants, and have a very good evening and a weekend. I hope to see you all again on the first Saturday of July for the next conceptual based course. So
thank you so much for this opportunity. Was glad to be part of this.
Wonderful.
Thank you
Thank you very much.
Thanks.